We are really delighted to have Dr. Ava Bittner, who's the Director of Vision Rehabilitation Center at UCLA Stein Eye Institute, here today to talk to us about Beyond 2020, Unlocking the Possibilities of Low Vision Living. And I'll have her come to the stage. Such an important topic, low vision, and so few low vision centers in the country, really. And so I'm so excited to hear your talk. Thank you for coming.
Okay, so I'm going to talk today about all different types of technologies and devices, so we've got it. But is technology going to be embraced? Is it going to be useful? Is that going to be something that people with vision loss are going to use? First, let me just talk about some of the typical, more common types of devices, which are magnifiers. And on the left are pictures of some of the portable electronic video magnifiers. And on the right are a couple examples of optical illuminated magnifiers. These are commonly prescribed in our clinic. When I look back at patients that we see at the UCLA Vision Rehabilitation Center, I was curious, how many patients are we recommending devices for? When I'm referring to devices, I'm thinking of just the standard ones like telescopes or optical or digital magnifiers. And they're recommended typically to about 62% of our patients. And of them, about half of them actually acquire and we dispense the device to them. Not everyone gets the device that's recommended, and that's largely because they're not covered, so it's usually self-pay for devices. About 38% do not get recommended a device, and that could be due to the patient preference. Not everyone wants a device. It's not appropriate for everyone. Also, a good number of patients I recommend high add powers for, so we can put some magnification into the spectacles in their bifocal or as near reading glasses and give them magnification that way. And then there are also free visual assistive apps, which I'll talk a bit more about later in this talk. And so that's another reason why maybe someone, isn't going to need or want a traditional device or aid. And you may be thinking, okay, well, that's all patients, but how about for glaucoma specifically? 12% of people with glaucoma were seen in the last few years, and the numbers are very similar. So 61% were recommended a device, and a little more than half actually got those devices. And the one difference we found was that people with glaucoma were a little less likely to get an optical magnifier. How about those with mild vision impairment? So if we look at just those people with vision between 2030 to 2070, you might not necessarily think that's low vision, but we still manage and recommend a lot of these devices for them. And so 40% of them received a high add power greater than 4 diopters. Half of them were recommended a low vision device, and about 63% were recommended a high add and/or a device. And if we look at just people with glaucoma, the numbers are very similar to those with any cause of low vision. Now, when someone gets a new device like a magnifier and they go home and start to work with it, there are a lot of errors, a lot of mistakes they can make, and they're not going to necessarily use that device proficiently or optimally to get the most out of it. And so there's a need for them to come back for return visits to reinforce the best use of those devices. And we know from a previous study done in the VA setting that having those return visits, that follow-up training, can help to significantly improve visual ability with new magnification devices when compared to no training. But what we've learned when I've surveyed low vision providers across the whole country is, asking them, how many of your patients actually return for their follow-ups for training? Well, the responses are quite a wide range, and what we're seeing is that maybe only about half of patients are able to get back in for training and for follow-ups. And so there are a lot of barriers. They may not be driving due to visual impairment. They may live far away from their vision rehab provider, or they have other types of medical conditions that require attention. And so a consequence is, unfortunately, what we see in the office, someone has a positive experience and does well with the magnifier, that may not translate into the home environment. And we also know that as providers, we're not very good at predicting who's going to do well with their magnifier once they get home or who's not. And so another unfortunate consequence is that about a fifth of the new devices are abandoned within just a few months after patients get home and work with them. And many of them believe that the magnifier is not effective for their needs, but really what they just need is a little more training and support from providers. So an approach we've been using over the last few years is tele-rehabilitation, and that's just using video conferencing between the provider in office and the patient at home in order to provide that support and training. And we've been conducting a multi-center trial to evaluate this. Now, many of the people we work with are older adults, and maybe they haven't ever used video conferencing or Zoom, or they don't even access the internet. So an approach we've made to give some accommodations for those who are not so tech savvy is to give them a loaner smartphone that has remote control access on it. This way, all the person has to do is, once they get the phone, is turn it on. Then I can remotely access it and log them into Zoom, get them all set up for the session. They put it into a stand. We use standard reading cards. And the provider can then assess how they're doing, see them with their magnifier, and give training. We assess how they're doing with their magnifier using a patient-reported outcome or questionnaire that assesses difficulty with reading tasks. And what we're finding is just giving someone a new magnification device, on average, improves their visual ability for reading by what would be equivalent to about 4 lines of vision. And so what happens after additional training? Well, their reading ability improves on average by about another 2.5 lines of vision. So having that opportunity to get that additional training and support can really improve vision and reading ability with these devices. And the outcomes were very similar between both groups when comparing tele-rehab to in-office care or training. Also, when we compare how people are doing with their reading from the first to the second tele-rehabilitation session, we find that most people are able to read even smaller print sizes with their magnifiers at the second follow-up, and about half of them also improve as far as being able to read more quickly with their magnifier. And when we ask people how they rate the tele-rehab session compared to in-office, we're finding that both are highly acceptable, and the ratings were not significantly different between groups when we asked them about things like whether their magnifier use improved, if they were comfortable with the session, if they were very satisfied with it, and if they'd be interested to have another session in the future if their visual needs changed or if they obtained a new or different magnifier. So what we're seeing is that either modality of care for training may be acceptable. Again, visual ability for reading improves with getting new magnifiers, but can improve even further with training. But not everyone is going to need magnification for reading. And another approach we use is enhancing the contrast of reading materials with task lighting. So for hard copy materials, we often recommend a desk lamp to improve the contrast. But what kind of lighting is best may vary from one individual to the next. And so we use a device called the Lux IQ, which allows us to give customized recommendations for lighting for reading hard copy materials. This little device allows us to vary the color temperature of the white light as well as the brightness of the light to make it most comfortable for the individual. And we can also assess whether having a colored tint might be helpful to make reading more comfortable. What we found in this study was that people with low vision tended to prefer white light instead of a colored filter when given both options for their preferred light settings. And so white light is sufficient as far as the task lighting. And we also found that people with glaucoma who did not have disease that primarily affects the rods and cones, they did not have disease primarily of the photoreceptors, they tended to prefer lower light levels than those with diseases like age-related macular degeneration or other diseases that primarily affect the photoreceptors. So it is important to customize the amount of task lighting for each person. And again, people with glaucoma are going to prefer a little less bright light. That means getting a task light that has an adjustable setting on it. Usually, if you need more light, we recommend you have to get it in really close to the reading material. And that can be tricky. You really need a gooseneck arm that can get in just a few inches away. But if you don't require as much light, that gives you more flexibility. The light may not need to be as close to the reading material. Then we also did another aspect of this study where we had people go home with a new task light and measured their reading speed for prolonged periods over 15, 20 minutes to see how quickly they read with and without the light. With the new task light, they read on average about 37 words per minute faster. And so a task light can be an important tool to help make reading more efficient and more enjoyable. Next, I'll talk a bit about visual assistive apps. And what I'm finding in my practice nowadays is we're recommending apps for the iPhone or tablet more and more often. And it almost turns into a question of, well, do you prefer an app? Do you prefer a traditional magnifier, or perhaps both? And we're conducting a clinical trial where we're evaluating 3 different apps. And what we're finding in the people participating is most of them are not even familiar that apps exist to help with visual assistance. A smaller proportion knew about the apps but said, hey, I really just needed some training on it. Almost everyone has a smartphone nowadays. And another key finding we're realizing is that people really do need a lot more training and support to become adept and proficient with using these apps. And so the 3 apps we're studying, the first one is Aira. Maybe you've heard of Be My Eyes. Aira is a similar approach. It's a company that hires and does background checks on remotely located agents who give live guidance with any kind of a visual task. So they're basically using the camera on your smartphone. You aim it or target, show them what you need assistance with, and they can help you with anything either inside the home or outside as well. It has, they can use your GPS to help you navigate. And they currently offer every 5-minute call is free. You don't necessarily need to pay for a subscription. And most tasks can be completed in less than 5 minutes. Another app we're studying is called Supervision Plus. That is a magnifier app, and some of our participants have found that they prefer it more than the built-in magnifier on the iPhone. And it helps give some more image stabilization. You can enlarge things if you need to, or enhance some of the contrast. A third app we're studying is called Seeing AI. And this one has a lot of different features. It can read text to you. It can identify things such as products, people's faces, currency, colors, scenes. So it really has a lot of features. We did focus groups in order to learn more about what people thought about these apps. And with Aira, the feedback we got was that the apps, it's nice to have that personal assistance from a real human who's there to help you when no one else is around. And they felt like, hey, I could use this out in public. It's just like talking to someone on my phone. It's not conspicuous like using any kind of other low vision aid. For Supervision Plus, the magnifier app, what they liked was, hey, now I don't have to bring an extra magnifier with me when I go out in public or go to the store or restaurant, and they can just use their smartphone in that way. And for Seeing AI, there are so many features. Really, they just wanted more time to be able to explore and get training on all the features available there. And so in our trial, a quarter of the people enrolled opted to have the training by tele-rehabilitation. And so we had pretty lengthy training sessions. The first one was about an hour, between 45 minutes to an hour. And what we found is if the vision was a little more reduced, they took a little bit longer. A fifth of our participants in this trial had glaucoma. And maybe not everyone after the first session was fully proficient and knew how to use the app, but after 2 or 3 follow-ups and training sessions, nearly everyone in our trial was able to achieve proficiency. And everyone in this study was age 55 and older. Some had never even owned or used a smartphone. And so we also wanted to find out, for those who did the training via tele-rehab, what they felt. And again, this was a highly acceptable approach for those who were comfortable with it and wanted to receive training that way. And so, since the pandemic, there's a lot more that's accessed on screen-based devices. And I had the question, okay, well, most all my patients, 90% of people over age 50 have a smartphone or tablet. Are they having difficulty seeing and using these devices? And so we did a review of our patients before the pandemic in the year 2019, and then compared them to during the pandemic in 2020 to see, is there a change in people's patterns of use for these devices, and are they presenting with the chief complaint or the main issue is, I need help with my screen-based devices. And we did find a significant shift from 11% before the pandemic to 30% during the pandemic. And that's their chief or main complaint. Often that's also a secondary complaint in our patients as well. And when we also account for other patient factors, we found there's about a 4 times greater odds of having a chief complaint of difficulty with your screens during the pandemic, and factors like their level of vision loss or their age or gender or what type of low vision they had wasn't necessarily related to having that chief complaint. When I look at this data, this period, about 16% of those patients had glaucoma, and we're still seeing that same pattern. About 10% had this main complaint before the pandemic, and then now that's shifted to about a third or so of patients more recently. And so what we're seeing is, okay, we are using our screens and devices more often, and it's going to be an important part of our practice to help support people with their screen-based devices and technologies. And so for that reason, we are hiring, and actually she starts on Monday, a new occupational therapist specifically to help support people with their devices and their screen-based technologies and the visual assistive apps. So she's going to be there for all the technology training. Now you might say, well, maybe I'm not too keen on using a smartphone for visual assistance. There are other devices like this one here, the OrCam, which does all the same types of things like the Seeing AI app, and is just a standalone device that you can clip it onto a glasses, or you can aim and point it at what you need to read things to you and identify different products or objects or people. Unfortunately, there's the cost, right? The apps are free, but these types of devices are expensive. But again, the option is there for those who are not too keen on apps. I'd like to touch a little bit on some of the wearable devices. So you think of the VR, AR headsets. Some of those have been developed for visual impairment. A few years ago, we had several of these in our clinic, so we wanted to evaluate what patients' experiences were with them. You can enhance the magnification, the color, contrast within these devices, so you're viewing things either distance, in between on the computer, at near, with these types of wearable devices. Some of them do provide a text-to-speech option as well. And when we looked at these a few years ago in our patients, on average, their vision was about 20/120. So this works best for sort of moderate to severe vision loss. But what we found was on average, their vision improved with these devices by about 4 to 5 lines as far as reading the eye chart at distance. Similar improvements by about 4 or 5 lines were also found for near reading acuity. So we see that these devices are helpful for vision, but they've not been the most popular just because of the way they're cumbersome, the comfort. And so companies are working to try to make these devices more like regular glasses, lightweight and more comfortable and easy to use. This is a newer version we have. This is the Iris Vision. They're trying to, again, make it look a little more like glasses. This is the iDaptic. This one is even lighter and is controlled by a smartphone. So again, I think the direction we need to go with this is to make these easy to use as far as the technology. A couple of things I'll just touch on. We do a lot of referrals to outside resources. So if you're in the Southern California area in either LA or Orange County, the Dale McIntosh Center, we refer, and then they come into the home and can help with vision loss. So that's if you're age 55 and older. And then the Braille Institute, we do a lot of referrals, and I'm pleased to see they've got a table out in the exhibitor hall, so please feel free to stop by and chat with them. And I'll also add that at UCLA, we're starting up a support group for people with low vision. This will be held remotely via Zoom, so it's open to anyone to join. And so I'll just leave this up here if you'd like to jot down, or you can call. The phone number is 310-825-6323, 310-825-6323 if you want to sign up to be part of these support groups we're going to be having remotely via Zoom for people with vision impairment. And these are going to be led by a licensed therapist who has a lot of experience working with people with vision loss. Our optometrists are also going to be on there to talk a little bit about how we manage and work with people who have vision impairment, but it's also there for people to connect and share their experiences and to offer support. So I'm out of time, but I'm happy to answer questions during the Q&A session, the panel at the end. Thank you so much.